Hello Xewani, Jambo, happy new year. Welcome to my channel and thanks for watching. My name is Bitumelo and today I am so honored to be talking to my gynecologist, Dr. Lebethe. He operates out of the Medforum hospital in Pretoria, South Africa, and has been in practice for more than 30 years. In fact, he delivered my baby sister, Bridget. Do you know how often you are supposed to do your pap smears? Is it every year, every 3 years, every 5 years? Did you know there was a link between PCOS and insulin resistance / weight gain? Answers to these questions and questions you might have on fibroids, on period pains, on endometriosis, and so much more coming up in this episode of Happy Period. I have added timestamps to this video so that you can go to a specific topic that you may be interested in without having to go through the whole video. Let's do this. I hope that our conversation will be helpful to you ladies out there. Dr. Lebethe, thank you so much for carving out space from your busy schedule to talk to us today.
An absolute pleasure.
For me, one of my passion projects, or one of the things that's very close to my heart, is fibroids. And I think when I first came to you, it was because I was struggling with fibroids, and I'd like for us to start there. Can you maybe tell us a little bit about what fibroids are and why do we get them?
Okay, thank you. What I'd like to tell you, to reassure you, is that you are not the only one. Lots and lots of women suffer from fibroids. Fibroids are non-cancerous growths that grow in the ovary. They can grow in all other tissues that have the same sort of cells as does the uterus, but they are the commonest in the uterus, and they are, as I say, non-cancerous. They have a very, very low association with cancer. They can become a cancer, but very, very low chances. And there's also an association with cancer of the lining of the womb. Now that goes probably into why people get fibroids. We don't really know why people get fibroids. We do know that there's a familial or maybe a genetic sort of inclination that if a mom has fibroids, the daughters are likely to have fibroids. And so there is an association with stimulation by the hormones, especially estrogen, because we do know that, for example, smoking inactivates or reduces the effect of estrogen. So some women, the women who smoke, are less likely to have fibroids than women who do not smoke. We do not, I'm not by, in any case, saying people should start smoking so to prevent fibroids. They're associated with not getting children, whether it's by design or people are not able to get children. And so we don't really know what causes them, but it's a strong association with not having children.
Is it a fact, or is it a myth that people that struggle with fibroids are usually people who have not been pregnant before?
Not quite. We do find, because of the background I've given you, we do find a lot of women with no children but no fibroids, probably because they do not have the familial or genetic inclination. But some women will have children early on in their life and spend a long time not getting pregnant. And some people will, for various reasons, career reasons, postpone having children. And those are the people in whom we tend to find fibroids. So it is not a cut and dry that you do not have children, you are going to have fibroids.
Right. And then how are fibroids diagnosed? So for me, one of the things that caused me to seek medical attention was because I felt my menses were heavy. Is that one of the side effects, or should I say side effect or symptoms?
Manifestations.
Yes. So how are they diagnosed?
That's probably the commonest manifestation, that people will have heavy menstruation, will have painful menstruation and may bleed in between the periods. But there are other manifestations like pressure manifestations where, depending on the size of the fibroid, if the fibroid is very large, then it will prevent the bladder from filling up. So people might find that they pass urine frequently, and it might press towards the back on the rectum and colon, and people tend to have constipation. And because of those pressure manifestations, you might find that people have swelling of their legs. But then again, because of the heavy menstruation, the people might become anemic, and as a result of that, have swelling of the legs on that basis. But basically, it's abnormal periods and pressure symptoms, and ultimately, they may also prevent a person from conceiving. So sometimes people present not with menstrual problems, not with pressure symptoms, but they're presenting with problems of wanting and failing to get pregnant. And when you examine them, you find fibroids that are in such positions that they may prevent them from conceiving.
Okay, so if anybody has excessive bleeding, how would we, before I ask that question, how do we determine if somebody says my flow is abnormal? How much do we actually bleed per month? What is normal and what is termed abnormal, so that if anybody thinks there's cause for concern, they can monitor themselves and maybe get medical attention?
Yeah, that is an interesting question, because I always say to people, biological systems cannot be put in boxes. Right. So we have ranges. Anything in terms of days between 3 and 7 days of menstrual bleeding is regarded as normal. Anything beyond 7 days may be a little bit heavy, and one would worry more about a change than what you are. For example, somebody will say, why do I have 5 days menstruation? My friend has 3. But then I say, you are not your friend, you are yourself. So then in terms of measuring the amount of menstrual loss, we talk about 80 milliliters, 80. But you can imagine that's difficult to assess on a day-to-day basis.
Unless you use menstrual cup.
Unless you use a menstrual cup, yes, or people sometimes weigh their pads and all of that, and look at the weight of the blood and all of that. But generally, a woman will say, this is abnormal for me. I'm not used to this. Then you know it's abnormal. And then, of course, we could look at what effect the menstruation has on the woman's blood. If she starts to have iron deficiency, and she starts to have anemia, which means the hemoglobin, which is the part of the blood which carries oxygen, starts to drop, and there is nothing else. She's not a vegetarian. She's not losing blood anywhere. It probably is heavy menstruation, and heavy menstruation is the commonest cause of iron deficiency anemia in women.
Mm-hmm. What are the different types of fibroids? Because I remember when I initially came to see you, the fibroids were not inside the cavity of the womb. They were sort of like around, and then lately we found some inside the uterus. So are they different, and is there a reason why they form in different parts of the uterus?
There's really no difference, no reason why they grow in different parts. So they grow in different parts. Some of them are on the surface, others are in the wall of the womb, and others may grow inside the cavity of the womb. But you can imagine something growing in the wall of the womb, and over years growing slowly, it might protrude into the cavity of the womb, and it might protrude outside, above the wall of the womb. So it's really a matter of size and a matter of site where it started growing that you find them in different places.
How big can they get?
Listen, fibroids can become very big. One lady that I saw was, believe it, pregnant, and she had at the time that her pregnancy was about 8 weeks. The fibroids filled her tummy like she was 8 to 9 months pregnant. So they can grow to very large. Where one has said to a lady, you are having such problems, it is better to remove the womb rather than to remove the fibroids, because removing the fibroids that are so many is going to cause you a lot of bleeding during the operation. You might require blood transfusion, and as we respect people's autonomy, if she says, I do not want to have the womb removed, I want the fibroids removed, sometimes you meet very horrendous things.
I'm glad you went there, because I once received that advice to have my uterus removed. So is that the only option that a person has? Now a person, yes, you are diagnosed with fibroids. What are the options available to a woman?
Okay, removing the uterus is not the only option. Obviously, the woman's desires and wishes have to be taken into consideration. So, as we said, fibroids by themselves are not a problem. It's more what they cause, like heavy menstrual bleeding and pressure symptoms. So, if the fibroids are small and they are causing heavy bleeding and surgery is not desired at that stage, and really surgery is a desirable method of treatment where the fibroids are in a place where they might prevent the woman conceiving and she would like to conceive. Otherwise, any other method of controlling the menstrual bleeding, the heavy menstrual bleeding, would be acceptable. So there is a loop which is impregnated with a hormone called progesterone. Progesterone is a hormone that prevents the growth of the lining of the womb. So if the lady is happy with that and it does not give her side effects, you've gone through her medical profile, you are happy with that and she's happy with that, you put in that loop into the cavity of her womb, and it will reduce or sometimes even take away the menstruation. So you've solved the problem. Then there's a procedure called uterine artery embolization, which is done by radiologists, where they, with their techniques, they put little pipes into the arteries of the groin, and they guide them either to the artery that supplies the fibroid or to the artery that supplies the womb, and they block those arteries with there's very small spheres that they inject into that. And when the fibroid is denied blood, it stops growing, it shrinks, and the symptoms improve. There are also medications that can be given, like we are giving that progesterone in the loop, that can be taken orally. Unfortunately, in our country, we do not have those yet, but there are other medications. There are other procedures that are done in other countries, like concentrated ultrasound waves that can sort of evaporate the fibroid. So hysterectomy, removing the womb, is not really the only thing. But, as we say, we respect people's autonomy. Sometimes you offer a lady alternatives and she says, listen, I want my womb removed. She has the right to decide that, as long as she understands the implications, the intraoperative complications, the long-term complications, whatever the case may be, and she's happy with that.
So we spoke mostly about the management of the symptoms, right? If somebody is not prepared to do surgery, or we can have a loop, or you can have the uterine artery embolization. So are you able to talk to us a little bit about the surgery itself, the surgery to remove the fibroids?
Yes. Now, if you have a fibroid in the cavity of the womb and it is causing heavy bleeding in between the periods, we do a procedure which is called hysteroscopy, where we put a little camera into the cavity of the womb, so a woman does not have to get a cut on her tummy. We put in that camera into the womb. There's fluid that we put in the cavity of the womb. We can visualize the cavity of the womb, visualize the fibroids, and we've got different instruments with which we can cut this fibroid into small pieces and get it out. So that would be okay for what we call submucosal fibroid, which is a fibroid in the cavity of the womb. If you've got fibroids on the surface or in the wall of the womb, then and they are giving you symptoms like pressure symptoms or painful menstruation, then you'd have to have abdominal surgery, which can be done either via laparoscopy, which we call minimal access surgery, where you've got a few small cuts on your tummy, or you can have a laparotomy, where the abdomen is open, the tummy is open with a big cut, usually a bikini cut. We don't usually do an up and down cut, we do a bikini cut, and you remove the fibroids. The laparoscopy or the minimal access surgery is good for maybe 1 or 2 fibroids. If there are many, then it becomes difficult, the risk of bleeding is increased, and then one may offer, if there are more, the laparotomy, where the tummy is opened and you remove the fibroids that way.
What is a myomectomy?
Myomectomy.
And a laparotomy, the same thing?
No. Laparotomy is when you open the tummy. Right. Whether you open the tummy for an appendicectomy, or for fibroids, removing fibroids, or even to do a cesarean section, that is a laparotomy. You open the tummy. Myomectomy, the medical word for fibroids is myoma or myomata, if there are many. So ectomy means to remove something. So myomectomy is to remove the fibroid. Ectomy, yeah. Like appendicectomy, ectomy, you remove the appendix. Hysterectomy, you remove the uterus. Yeah, that's the thing there.
Okay. Thank you. I think we can move on to the next one.
Good.
I now want to talk about pap smears. So I think the first thing I want to know is what is a pap smear and why must we have them?
Pap smear is a clinical procedure where we collect mucus from the cervix, from around the cervix. This mucus contains cells that fall off or discommate from the cervix. And these cells can then be examined in the laboratory by somebody who studies cells called a cytologist to see whether there are pre-cancer changes. So a pap smear is done on a normal cervix to pick up pre-cancer changes. As a matter of interest, cancer of the cervix is the only cancer in the body that we can prevent. It's the only cancer which has a pre-cancer test, which is the pap smear. And therefore, we can prevent cancer by doing that. By detecting pre-cancer changes, they can be treated so that a woman never has cancer of the cervix. Now, pap smear is very important. You ask, why should we have a pap smear? To prevent cancer of the cervix, because in South Africa, between 10 and 12 women die on a daily basis from cancer of the cervix. And close to 7,000 women per year will have a freshly made diagnosis of cancer of the cervix, simply because the healthcare in the preventative sphere does not reach everyone. And so we do find people presenting with advanced cancer of the cervix that you ask about pap smear and they say, what is that? And there are many reasons why people do not have pap smear: fear and being told it's painful and whatever. And I always say it is uncomfortable to have a pap smear, but it is the lesser of the evils than having cancer of the cervix, than to have pre-cancer detected and treated so you never have cancer of the cervix.
So this question always gets me different answers. How often must we have a pap smear? 1 year, 3 years, 5 years? Which one is it?
Yeah. Now, how frequently one does pap smears depends not only on the science of the biology of the problem or the pathology, but also on what people are able to do from a financial point of view. For example, in state hospitals in South Africa, the women will be told you have a pap smear when you are 30 years of age, when you are 40 years, and when you are 50 years of age. That is what the government can afford in terms of the financial outlay, but that is probably not the best, because you are going to miss a lot of cancers. In the first world, where probably people who have medical funders would fall into that category, it would be said maybe from the age of 21, some researchers say from 25, you have your first pap smear. And then you have one the following year when you are 22 years of age, then another one when you are 23. And if all those three are normal, you have one after every 3 years. And if you continue with normal pap smears every 3 years, when you get to the age of 65, and your last pap smear at 65 is normal, you can generally retire from doing pap smears. Now, this is because those pre-cancer changes are caused by a virus called the human papilloma virus, abbreviated HPV, which is transmitted by intimacy. So the presumption is that as people grow older, their sex life become more stable. So they are less likely, if they were not exposed to the virus, to get the virus later. And incidentally, if you get exposed to the virus in the 20s and the 30s, and it is going to cause cancer in you, it's going to cause cancer when you are in your mid-40s or 50s. So it takes a long time. So contrary to what people think, that because I'm older, I must have more frequent pap smears. As you grow older and your pap smears are normal, you need less pap smears because you are less likely to have problems.
Does this mean if a person has not been sexually active before, there's no need for them to have a pap smear?
Not necessarily. It depends on what we mean sexually active, because even for women that are lesbian, when we say it's transmitted sexually, it's transmitted by skin contact. So it might be that even those lesbian women have encountered the virus with their fingers or their skin and anywhere. And so the protocol for screening applies to the heterosexuals as to the homosexuals.
So if you've now missed the 21, 22, 23, those first 3 years, and now you are in your 30s or 40s and have never had a pap smear.
Yes.
Do you start that way? Like now I'm 39. Does it mean if I'm now, I'll be doing one this year, 39, next year 40, another one at 41, and then 3 years after that?
No. What we have recently in the last 10 years or so is the ability to test for the virus. which is a better test to do because it's a DNA test, it's a chemical test, it's not a subjective test like the pap smear where somebody looks at the cells and thinks they're abnormal or not normal. So even those women that we put on a 3-year pap smear protocol, when they get to about 30 or 26, whatever, depending on the protocol that one adopts, then we do the HPV test. And if the HPV test is negative, then we know we can screen again after 5 years. Remember, we said it takes 10 to 20 years to cause problems. But if it's positive, because the pap smear itself is not a very reliable test, being about 50 to 60% reliable, then if a woman after the age of 30 onwards has the HPV, it is probably a virus that she's had for a longer time than just that time. So the chances that she might already be developing some microscopic precancer changes is high. She's then exposed to a test called a colposcopy, in which we use a magnifying machine with which we examine the cervix, and we stain the cervix, and interestingly we stain it with vinegar, which is acetic acid. And when people get into my room for that, they say, "Do you have chips in here?" Fried chips. It's acetic acid. We stain it with acetic acid, and the acetic acid brings out the abnormal areas. You can then take a sample of those areas, which we call a biopsy, a little bite. You send that to the laboratory. The laboratory examines the tissue, and they can tell you whether there is significant precancer change which needs treatment or there isn't. The fact that there's HPV on the cervix does not necessarily mean there's precancer change, but one has to make sure. And the fact that the pap smear is normal does not mean that there's no HPV, because it might be that the HPV is there, it has not yet caused problems, or the pap smear being not such a reliable test has missed the abnormality.
So an HPV test is a different one, is a different test from a pap smear?
The sample is the same that we take,
Right.
but it's exposed to a different chemical process or testing process in the laboratory.
Is that something a woman would request from a gynae, or is that automatically done? If a person says, "I'm going for a pap smear," are you able to request that an HPV test is done, or is that an automatic?
It is not automatic. It depends on a number of things, but I think your gynecologist would say to you, "You want a pap smear? Let's discuss, what this means and all of that, and then we have this test." And because it's slightly more expensive than the pap smear, a woman might decide, "I do not have budget for that. Let's do the standard pap smear." But if she can afford that and she's happy, she understands what it's all about, and it gives her a longer time for a screening if it is negative, and it gives her access to better testing if it's positive than what the pap smear might give her. So there are a few determinants as to whether an HPV test is done or not. But generally, we would recommend that you have an HPV test as opposed to a pap smear.
Awesome. Thank you very much. I feel so empowered today. Now, a topic that I don't know so much about, PCOS. I have two friends who have PCOS, and every time we talk about PCOS, my mind goes, I don't understand. Yeah, I don't understand. And funny enough, both of them have fertility issues. So I thought it might be interesting for us to talk a little bit about that. What is PCOS and how does it present in a person? How would a person think they have it? And what are they looking out for to come see a gynecologist?
Yes. Well, this word PCOS is probably a misnomer for the condition, but it describes the appearance of the ovary on ultrasound examination, because when you look at that ovary on ultrasound examination in a woman who has polycystic ovary syndrome, they have those little cysts all over the ovary, and because your normal ultrasound is a two-dimension thing, it looks like the ovary is oval, then at the periphery, at the edge, it's got this what looks like a string of pearls. But that physical appearance you'll find even in women who do not have the polycystic ovary syndrome. So that does not make the diagnosis of polycystic ovary syndrome. The diagnosis of polycystic ovary syndrome is diagnosed on the irregularity or absence of menstruation, and the manifestation of high levels of the male hormone in a woman, the male hormone being testosterone. It could be either a physical manifestation where she has male sort of appearance of the hair distribution, or it could be also the lab diagnosis that she's got a high level of testosterone. So that's basically how we make the diagnosis. There must be, a lack or infrequent periods, there must be manifestations of a high testosterone level or a laboratory assessment of a high testosterone level. That's when you make a diagnosis. So it is really a story of a chicken and an egg, but basically the women are not ovulating regularly, which is why they are developing the absence of menstruation, and that conception is difficult for them because of that. And because of the non-ovulation, the non-release of the egg from the ovary, the capsule of the ovary becomes quite thick, and that is the area of the ovary that produces the testosterone. That's why I'm saying it's a chicken and egg story. So we don't really know how it begins, but that is the manifestation, and that is why they have problems getting pregnant. And the diagnostic criteria have to be obeyed, because any woman, if you miss 1 or 2 months, I can't really say you've got polycystic ovary syndrome without doing the proper test. And that is the problem, that we get that diagnosis made very frequently in women that may, for some reasons, I mean, for example, if you were placed in Germany and you don't speak German, you are so stressed, nobody that you know, nobody you can speak to, you might actually go for 2 or 3 months without your menstruation. Do you have PCOS? No, you don't have PCOS. It's just the stress that's taking away your period. So the diagnostic criteria have to be obeyed in order to make the diagnosis.
So what can they do? What are can it be reversed? Can it be treated successfully and the people manage to fall pregnant again?
Yes, it depends.
Again, fall pregnant?
Yes, that is actually the operative requirement. Do you want to get pregnant now or not yet? If you do not want to get pregnant, you could be put on a contraceptive pill. There are those specific contraceptive pills that are indicated for PCOS. The few things that the pill will do for you, it'll give you predictable menstruation. It'll give you menstruation, it'll give you predictable menstruation, it'll make sure that there is no unwanted pregnancy, unplanned unwanted, and also it tends to take away those manifestations of high testosterone levels, like the male hair distribution, the acne, the oiliness of the skin. But then when a woman wants to get pregnant, then there are medications that can be used to stimulate ovulation. There are pills that can be given at a certain time, and if they're not working, there are injections that can be given together with the pills. And if those are not effective, we can the one thing that we haven't mentioned about PCOS is that it gives you what we call peripheral insulin resistance. In other words, your body does not respond to the insulin, so you tend to have a tendency towards diabetes. You tend to put on weight, which is really difficult to get rid of. And so if they're given medications that what's the word I'm looking for, that promote insulin sensitivity, then you might find that the weight drops and they start having their normal menstruation. And also in terms of weight, if a woman gets onto a program that makes sure that she loses a few kilograms, 2, 3, 4, 5 kilograms, then the menstruation comes back and she's able to get pregnant. And if all these things have not worked, then there's a procedure that can be done in theater, which is called ovarian drilling. It's done via the laparoscopy.
That sounds painful.
It's done under anesthetic, general anesthetic, so you will not feel anything. Ovarian drilling. It's essentially a very simple procedure where a heated sort of needle is used to puncture different areas on the ovaries. By so doing, you reduce the amount of that capsule, which I said produces the testosterone, and quite often that works, and they start ovulating. But you start with the least invasive treatment and escalate if you still encounter failure to produce ovulation and pregnancy.
I think together with PCOS, another interest of mine is in endometriosis.
Endometriosis.
Yes.
Yes.
Because it's also a word that I'm hearing a lot.
Yes.
Recently.
Yeah.
So what is it? What is endometriosis, and what do we look out for?
What do you look out for? Endometriosis, in medical English, osis means a lot of, as opposed to itis, which means inflammation. So if there was, the endometrium is the lining of the womb. So if there's inflammation in the womb, we say the woman has got endometritis. But endometriosis is where a woman has cells which look like the cells of the lining of the womb, distributed outside the normal cavity of the womb. It could be all over on the pelvic floor, it could be on the ovaries, on the tubes, it can even be in the lungs, it can be anywhere. And sometimes when a woman has had a cesarean section where the womb is opened and it is cleaned, some of that lining of the womb implants in the scar, in the operation scar, and sometimes we've seen it also in the belly button. So it can be anywhere. Now, interestingly, there was a time when black women were believed not to have endometriosis, which is a fallacy. I mean, it's a remnant of or it's a legacy that black women had infection and women had endometriosis. Right. Nonsense. Black women have endometriosis. And how we know a woman has endometriosis is she will have heavy menstruation, she'll have painful menstruation, she may also have bleeding in between periods, much like fibroids. And sometimes, because the endometriosis tends to collect behind the womb, in front of the rectum, that space that is behind the womb, at the bottom behind the womb, in front of the rectum, if it collects there, or when she's menstruating, because what happens is the lining of the womb gets stimulated by the hormones coming from the developing egg. So the lining of the womb grows. So whatever it is, the lining of the womb will grow in response to that. And when the woman is not pregnant, as a result of the ovulation, and the endometrium breaks down and comes out, that's menstruation, she'll be bleeding also in her tummy. So blood is very irritating, and it collects in that area behind the womb. And she'll often tell you, when I'm on my periods and I have to go to toilet to pass stool, I have extreme pain. Ooh. And also, we have a severe form of endometriosis where the endometrium is implanted in the septum between the vagina in front and the rectum at the back. That's called rectovaginal, means between the rectum and the vagina, rectovaginal disease. And when that woman is examined, when the finger is put behind the cervix on internal examination, she feels severe pain, and doctor will say there's something hard there. And those are the women who tend to have pain when they're having intercourse, especially on deep penetration. So endometriosis is a very common condition. It stretches from very mild to very severe, the severest being this rectovaginal or deep infiltrating endometriosis. And if you take the eponym or the abbreviation for deep infiltrating endometriosis is DIE, which is die. I die when I have intercourse. I die. Right. Deep infiltrating endometriosis. Sure. So it's a very common condition, and once again, how we treat it depends on whether the woman wants to get pregnant or not. I mean, we see very young women. I had a 21-year-old with endometriosis. She doesn't want to get pregnant. So at that point, you take care of symptoms. So she can be given medication at the time that she has periods to take away the pains. She can have the loop that's impregnated with hormone. There's a smaller one that can be fitted in the wombs of younger women. And when they then want to get pregnant, they might have surgery at that stage if they're failing to get pregnant, which is, once again, the best is minimal excess surgery, which I spoke about, laparoscopy, where most of the endometriosis can be removed.
Is it a physical thing? Is it a physical skin?
It's a physical thing. It's like you've got, sometimes when women menstruate, sometimes they pass something that's like a piece of flesh, which is called an endometrial cast.
It looks almost like a liver.
It looks like a liver, yes. So you'll find those sort of things in the pelvic cavity or in the abdominal cavity. And when you look at it with the laparoscope, it looks like this collection of menstruation. Is dark menstrual-like blood, and there may be, quite painful lumps under the covering of the tummy inside. So it is a physical thing that then can be dissected and removed and taken out. Yeah.
That sounds painful.
It is painful. It's painful to have the endometriosis. It's painful to have the surgery. After the surgery, there's pain for a few days, but then if it is done properly, and not every Tom, Dick and Harry gynecologist can do that. I, for example, will regard myself as not quite qualified to do like deep infiltrating endometriosis. So I have a few people that I would refer to and say, that person knows this, does this on a daily basis. I'll send that to them. So one has to be careful about saying, you've got endometriosis, I'm going to do laparoscopy on you. What experience do you have? Yeah.
So now that you mentioned menstrual pains, I know the medical term is dysmenorrhea.
Yes.
Did I pronounce it correctly?
Dysmenorrhea, yes.
Is it different? So if I'm having I don't know, I'll say a normal, are they normal? Having a period pain, is that normal? And is a cause for concern. If I'm having a period and I have period pains, can I just ignore it and just let it pass, drink whatever pain tablets, or is it something that I should be looking at?
Yes. The answer to that question really is it depends on what's causing the menstrual pain. We have what we call primary dysmenorrhea and secondary dysmenorrhea. So in secondary dysmenorrhea, we've got an obvious cause like fibroids or endometriosis or any other condition, old infections. They can cause this secondary dysmenorrhea. Where we call it primary dysmenorrhea, it's when we do not find the cause. It may be that there's a cause, but science has not developed to the point where it finds the cause. So whether or not you ignore it depends on how bad it is. And obviously depends on the cause. So where a woman has not had dysmenorrhea, painful menstruation, and she suddenly develops dysmenorrhea, I think it is wise to see a doctor and have an examination, and maybe there's a cause that can be treated and you don't have to suffer. Women do not have to suffer from dysmenorrhea.
Oh, no, we don't.
You don't have to.
But a lot of us do.
When the lining of the womb breaks down, there is a chemical that comes from it. It's called prostaglandin. Prostate. Mm-hmm. That chemical can be found in the man's prostate. In its purified form, this chemical is used to induce labor, to induce termination of pregnancy for whatever reason. So it stimulates the muscle of the womb to contract. In the body, we have two types of muscles. We've got what we call striated muscles, that is in your arms and in your legs that you control. Then we've got smooth muscles that are controlled by the nervous system without your say-so. So the smooth muscles reside in the womb, they reside in the bowel. So that's why some people who have dysmenorrhea, at the time that they have their periods, they may have diarrhea, they may have vomiting, because the smooth muscles are also stimulated by this prostaglandin, which then makes the muscles contract faster and quicker and stronger. So that's what causes dysmenorrhea. So where a woman has lots of endometrium, like endometriosis, there'll be more prostaglandin. Where she has fibroids and the womb is large, so the surface area of the cavity of the womb is large, so there's more endometrium, so there's more prostaglandin. But it also depends on the person's the body's response to the prostaglandin. Some people don't have such a severe response. So once again, biology cannot be boxed. You can't say this is going to happen. So that's the situation there. So it's because of that prostaglandin, and that is why medications that are called antiprostaglandins tend to work very well in people that have dysmenorrhea.
What is one advice you can give to women as it relates to their health?
I would say if you want to know the way to heaven, you speak to your priest. If you want your car fixed, you speak to your mechanic or your garage. If you want your house fixed, you speak to a builder. So I think the best way to get your health looked after properly is to speak to a doctor or even a gynecologist. Your GP will be able to do most of the things, and will then be able to refer you if they get to a point where they say, I don't understand. But things like you go to the doctor with a headache, and the doctor says, I just want to check your blood pressure. And you say, has it got to do with anything to do with the headache? Maybe, but high blood pressure has no symptoms. So I'm going to check it anyway, because we may prevent catastrophe as a result of that. So there are certain things that a woman would have to have done on a regular basis without having any symptoms, like as we spoke about the pap smear, mammography when they get to a certain age, that will pick up cancer early in the breast, and just your general examination. So go to the doctor. Don't go to all those social media platforms that will not be specific to you. They'll give you general information where people write what they like, and it's not necessarily true.
I know I'm at the end, but because you mentioned mammography, can you talk a little bit about that? I didn't actually know you see a gynae for mammography. Yes,
your GP could send you for a mammogram. Your surgeon could send you for a mammogram. The thing is, women would go to a gynecologist. Yes. I have a breast lump, they'll go to a gynecologist. There seems to be this inexplicable difference that, for example, in the UK, which South Africa has copied, that the breast is looked after by specialist surgeons, but women will primarily go to a gynecologist. In the US, the surgeons will look after that. So it really depends on where you go. But any doctor should know that in their country at a certain age. If you have a family history of cancer of the breast, you should start doing mammography. If you do not have, you should do mammography from a particular age. In South Africa, if you do not have a family history of breast cancer, the Cancer Association of South Africa says from the age of 40, you should have a mammogram on an annual basis. If you remember when we spoke about pap smear, I said cancer of the cervix is the only cancer we can prevent. So mammogram does not claim to prevent cancer of the breast, but mammogram says, I will pick up cancer, changes that indicate cancer, before you can feel a lump in your breast, and therefore very early, and presumably then the outcome of treatment is good. So you'll find that different authorities have different protocols. As I say, in South Africa, 40 years, once a year. Some people in the UK will say from the age of 50, once every 2 years. Similarly, in the US, some counties will do that. So we stick to the local authority. Yeah. Because if we treat you according to Americans and you get into trouble, then we are in trouble.
So if you do not have a history of breast cancer in your family, you can do your first test when you are 40.
40 years of age.
If you have history?
35.
35.
And the one thing that is often forgotten is a mother gets diagnosed with breast cancer and she's not told, listen, you must warn your daughters. I mean, that the doctor should do that. But, people that read will also say, my mom had breast cancer, maybe I better look,
Thank you very much, Dr. Lebethe, for your time. I really appreciate this conversation. I'm sure it's going to be helpful to a lot of ladies. And when I'm in South Africa again, maybe we can do a part 2.
That will be a great pleasure. And thank you for making the time to speak to me about gynecology, a subject that I'm very passionate about, obviously being a gynecologist. And I wake up every day happy that I'm going to see and manage to solve some women's problems.
Thank you.
Good.